Here we are. Welcome to London, guys. Welcome to London.
Thanks again, Lorenzo, for this amazing opportunity. And is there also, the remote control? Perfect. So CFA, what's the present, what's the future? I try to bring some movie concept also in this presentation. These are my disclosures. So, like Lorenzo mentioned very clear in the introduction, I think that the common femoral artery right at the moment is one of the most controversial topics. Why? There is controversy about the anatomy, about the diagnosis, and last but not least, of course, about the treatment. Without judging it, I'm just going to give you some ideas out of the literature that you see over there. So in terms of anatomy, if you read different papers, and I can guarantee you I've read a lot of papers on the common femoral artery. In some papers you notice that femoral bifurcation involvement is in 10% of the cases, and in some other you notice 80% with femoral bifurcation. Yeah, what is it now? Is it 50-50 or whatever? Then the extension to the external iliac artery under the pupar ligament. Is this a compression area? Yes or no? Depending on the paper you read, you notice that there are some different arguments, and even more on flexion side. The first cases I did with some stent implantation in the common femoral, the people, they say, but you are crazy, Dr. Deloose. You are completely crazy because you're going to have stent fractures and whatever. I went to some of the interesting studies, Park and so on, Andrews, showing that in dead body experiences, there is no movement at all of the common femoral artery. It's a very fixed segment, just proximal to it, external iliac, a lot, just distal to it, proximal SFA, a lot. But in between, no movement at all.
Can you say it again? Say it again, please.
It is clear, I think.
Yeah, I mean, it's not clear. It's like people, despite there's plenty of literature done on cadavers where they bend the legs and they move everything, people don't believe it. So, I mean, it's fantastic, you know, you do studies, it's like it's very physical studies, not like rocket science, and people still don't believe. So
absolutely,
that's something to work on, you know.
Absolutely. Access site, well, this was for me at least a defined certainty. So, okay, it's an access site, it's correct. But if we listen to Rafael Koskas this morning, it's not an access site anymore. You can do everything from distal, and you can doing everything from radial. That's a joke. It remains a very important access area. One thing that everybody agrees is about the histomorphology, and this is coming back also in all the papers, calcium plus. And there are bone signs, bone histopathological specimens with really some osteoblasts, bone marrow and whatever in the specimens of the lesions in the common femoral artery. Diagnosis, well, I think everybody agrees that if we want to judge the severity of the stenosis, that we need to use duplex ultrasound. It's easy accessible, easy to do. The extension, well, that's a little bit the definition that is used. In some papers, they use the AZEMA classification, as you can see over there, but in some others, completely different grading and classifying systems are used. So also there is some controversy. And then how to assess the amount of calcium. And that's also, and I've seen a very nice paper of Kaneta and Hani Zayed about calcium assessment. Based on CT scans, he's creating some subvolumes and is extracting one subvolume calcium. And in this way, you can see me quantifying this amount of calcium and speaking in more or less objective terms on the calcium assessment. Then sizing, the whole discussion ongoing. Do we use IVUS? Do we use EVUS? Do we use OCT? Sizing, how to size, I think sizing is extremely important also for treatment in the common femoral artery. But again, a lot of controversy. And then last but not least, as I've mentioned, therapy, gold standards, endarterectomy, no discussion about this, but there are a lot of endovascular challenges right up to now. And which endovascular alternatives? Well, what are the prepping modalities? IVL, regular balloons, specialty balloons, atherectomy, nobody knows. Angioplasty-based treatments with DCBs or whatever, or do we need to use scaffolds? So a lot of discussion is ongoing. I see that Lorenzo is becoming very disappointed because he asked me...
Also a bit more bold than what I already am.
You need to use a case. It's a case-based presentation. Okay, Lorenzo, I come over there with a case. 72 years old male patient, cabbage, COPD, so quite a lot of comorbidities, risk factor, obesity, Belgium. I've seen there on the amazing drawings that Belgium is already on the plate. So also there, the land, the country of beer, chocolate, fries, obesity, body mass index 31 is more the rule than the exception. Hypercholesterolemia, identical, and diabetes type 2, this patient. He's claudicating 50 meters, so a Rutherford tree, and that's the lesion. So we are talking about this lesion, we are talking about this outflow, and so we are talking about an azema C or 3 classification. That's the case we have. So I want to ask you, based on the different colors, red, common femoral and arterectomy, green, an endovascular approach, whatever it is, or yellow, nothing. Leave it there, let the patient claudicate. I see a lot of red, I see some green, and I see one yellow.
There's one in the house that don't believe in treatment for claudicants.
At least not that first approach. I would probably initially try to adapt the medical therapy, exercising and that stuff. And then obviously depending on how many meters, not saying that I wouldn't treat, just not jump right on based on that.
I think I can completely agree with this comment. Definitely, you can say this here in the room. If you know the patient personally, I can guarantee you that this is not going to offer you any, he's completely dismotivated, unfortunately. And so he said, Dr. Deloose, I need to have a solution here, hic et nunc, here and now. So, but I fully agree with your comment. I think you're right. Anyway, so green and red.
Can I just ask you, it's controversial, I know, but the rules or the threshold for the indications is the same for the endo and for the common femoral artery?
Identically the same.
Okay.
We need to judge it in the same way. So, yeah.
It's a very controversial lesion because if it was a single common femoral lesion, probably it would have been even easier to decide. In this case, like if you read the CONFESS study, still from the same group of St. Thomas's, they are dividing, you know, based on the azema classification, the severity of the lesion compared also to the anatomical segment. And this is a lesion which involves, not even, it doesn't really dive into the profunda, but definitely involves. It goes across, for sure. So
it's the reality.
I think a good thing would be to randomize this patient in a trial.
Probably we did.
Well, you are really making the rest of my presentation, actually. I didn't randomize it, but I don't know if you know the movie Sliding Doors, which is one of my favorite actresses, Gwyneth Paltrow. So you know the story, I'm sure, or she is catching the train, and then there is a completely different scenario as she is not catching the train, and then there is another scenario. And so it's a recommendation. So I tried to mimic this, and you see the background is London, so it was actually here in this city that this movie was played. And so, Sliding Doors, one day I decided to do an open-end arterectomy in this lesion. And so here you see how nicely this endarterectomy was performed. I can play the movies, but I think the surgeons, they know everything about this. So the dissection all the way up to the common femoral artery, quite easy, straightforward. Even in obese patients, nicely encircling the SFA, the profunda, and the common femoral artery, ligating some of the overcrossing veins and whatever, and then afterwards opening the lesion and taking out this amount of calcium, this coral reef bone, as you can also see it here on this picture. It's nicely done, as you can see. And this is actually also for the cardiologists and the interventional radiologists. That's the disease that we are taking out of a groin. So you need to be a little bit crazy to try to treat this in an endovascular way. But anyway, you see immediately also the weakness. And as a vascular surgeon, I can say this. the weakness at one moment, because the disease is also extending distally in the profunda and also proximally, at one moment, you need to break somewhere the plaque. You cannot do an endarterectomy up to the aortic bifurcation or the aortic arch. So you need to break the plaque, and nobody is asking me in the vascular surgery world, yeah, but what's happening there at this zone where you are breaking the plaque?
Because you can close it. Essentially.
You close it, nobody is seeing anymore. There is no criticism. It is the gold standard, and it remains the gold standard. Okay, so nice patch. Look at this. You close it, a nice patch on it. Beautiful surgery, honestly. I love this operation. It's clean, it's perfect, it's easy, it's no stress. Beautiful. And at the end, you are closing everything very carefully without any problem. Beautiful, small scar in the groin. The patient is not aware of an operation. General anesthesia, 3 days of hospital stay, and aspirin monotherapy after this operation. Okay? Question.
So my question is, aren't you performing post-op angio just immediately on the table?
Never done. Is there one vascular surgeon here in the room who is checking after an endarterectomy with angio? 2, 3. 3 people. Yeah. You are bright examples of how the modern vascular surgeon needs to think, but no other vascular surgeon is checking this. And then you, if I can ask, you puncture the contralateral side? How do you do this?
No.
Okay.
No, from, through the same side, just with a needle. But on the first picture, you see there is also a very severe stenosis on the femoral profunda. And so with surgery, you cannot treat, or you need to have an extensive dissection.
Bright minds. You can do this, but like you mentioned, you need to open it for 5 centimeters more to go all the way on the profunda. So we also know the longer the operation, the bigger the incision, the more dissection, whatever lymph leakage, wound infection is increasing. Also with this kind of operation. So correct point. Well seen on the angiography.
Thomas.
Yeah, so typically I would go through the patch. So it's totally safe, easy to close. So, I mean, no problem there. But the other thing, when I do crossover, so typically try to do blind endarterectomy above the iliac. So it's a very safe place to put a balloon expandable stent. So it's not moving part above the iliac. And you can do it blindly, actually.
I'm very happy that you are saying this blind. You need to say this in the endovascular world. Yeah, but I'm doing this blind. In the surgical world, everything is blind. But in endo, nothing is blind.
No, I mean, you can do it more advanced, so I don't want to stress you. So actually,
what
I'm doing, I'm taking more rings, I'm placing wire, placing balloon, cutting that and grabbing with expanded balloon and more rings, everything out. So it's up to internal, but it's more advanced, let's see.
I like this approach, absolutely. So, and I'm going to say you some more at the end of my presentation, because currently we are also doing this because of another reason. Okay, so that's the one approach. Sliding doors. I was not in my open mind, in my open, let's say, feelings. I say, no. I'm going to treat this lesion endovascularly, the same lesion. We are talking about, so scenario 1, scenario 2, same lesion. So I decided to go crossover, to implant a 45 centimeter 6 French sheet. And I tried with my Advantage guide wire 018, supported by a nice Navicross, to drill, as you can see over there, to drill all the way intraluminally, by preference, towards the distal area. And my wire decided at one moment, and my Navicross, as you can see, decided to jump into the deep femoral artery. There you go. So no subintimal, nicely, but you need to take your time, not making a loop and going all the way through and through. No, step by step drilling like the Japanese friends and try to get into the distal area. So there you see with my Navicross catheter angled, it was rather easy to switch right at the femoral bifurcation, the direction, and to steer my wire into the SFA.
Can I say one thing? Guys, never approach lesions like this with an O35 guide wire. That's something that we need to understand. You will never cross this intraluminally with an O35 guide wire. So try to think about switching from an O35 classic approach to an 018, 014 in these lesions, because it's going to be a game changer. Sorry.
No, thank you for this important remark. So, vessel prep, we discussed this already this morning. If you are rich, if everything is reimbursed, you can use immediately a lithotripsy balloon, a shock wave to break, to modify the plaque. We are poor, as I've mentioned this morning, so I use regular balloons. Here, for the demonstration, I started like with 3, 4, 5 meter, but in the reality, I try to start immediately with a 1-to-1 vessel balloon ratio, so a 7 or an 8 millimeter balloon. But sometimes even that is too bulky, and you need to start with smaller sized balloons. But 1-to-1, and even if you can, slightly oversizing 1.1-to-1 balloon vessel ratio. And then I decided I'm not the biggest believer, but probably lack of experience and also reimbursement of the DART, the directional atherectomy and drug-coated balloons. So I decided to implant a reimbursed Supera. I did a good and extensive vessel prep. You need to see it very well. So as you see here, a field of view 16 centimeter, magnification, a good LAO, and then step-by-step deploying, and from healthy to healthy. We discussed this already this morning. So I start in the SFA, close your ears, because for a lot of people, this is really a sin that I'm doing here, caging the deep femoral artery. So start in the SFA, and then step by step, I selected here I think a 7.5 Supera millimeter diameter. I cover all the lesion with this stent. And that's the result after stenting. Like the colleague mentioned very clear, there is not only an ostial lesion at the deep femoral artery, there is also a more distal lesion that is very hard to reach with open surgery. So I decided with my same Advantage guide wire, so always the same guide wire, I tried to go in between the closed-end loop wires of the interwoven Supera stent to go to the deep femoral artery, and with a balloon, I think a 4 or a 5 millimeter balloon, to dilate and the distal profunda lesion and the proximal profunda lesion, as you can see over there. So no problem with this kind. Probably with some conventional nitinol laser cut stents, it can be a problem. You can damage the struts. Here, with the interwoven character of the Supera and the 6 pairs of closed-end loop wires, there is no issue of damaging. So, sliding doors. Result on one side, the same lesion. You see a nice patch, good flow to both vessels, but still the remaining profunda lesion over there. The result endovascularly, a nice stent instead of a patch, and the lesion in the deep femoral artery is treated proximally and distally, and a nice flow to both arteries. The result is not always with open endarterectomy, like I've shown you before in our case. These are some other pictures where the people were so brave to take an angio. You see, clamp lesions on the deep femoral artery, some remaining part over there, an occlusion of the SFA, some aneurysm formation or pseudo-aneurysm of a leaking patch, even a full occlusion. And so stating that the endovascular, the open endarterectomy is the surgery of the world with no bad results, I can argue against this. Probably it's because these surgeons are bad surgeons, yeah, but probably it's also the daily reality. To be honest, I need to be honest today, Lorenzo told me, also endovascular can create some problems. Here I show you one of my cases where I did the same treatment more or less in the common femoral artery, and you see a major distal embolization in the deep femoral artery with a complete block over there. So also in both arms, that's my message. in both arms, you can encounter important complications.
Joele.
I have a question regarding the case. In such a situation, in case you are left with dissection at the ostium of the common femoral, of the profunda femoral artery, after positioning the supera across the ostium, what would you do?
Yeah, that's right, the difficult point in the endovascular approach. So I'm really not in favor. I know that a lot of my colleagues, they are willing to implant a second stent over there to go through the struts or the wires of the supera and implant a stent there, balloon expandable or self-expandable. I'm not in favor of this, honestly. So I still don't have a perfect solution like our friends, the cardiologists, with bifurcated stenting. There is room for some innovation over there. So having said that, I try to do whatever I can to avoid this. I do a vessel prep in the same way, prolonged inflation time, 5, 8, 10 minutes if necessary, gentle, low pressure, and then afterwards the DCB, the same approach. So I try whatever is possible to do to avoid this kind of dissections, but sometimes I fail, I agree. I leave it like this, and I'm following up, and we will see. I see pictures all the time of angios leaving nothing behind, and they leave it all the way with dissections, and look, 2 days later, it's perfectly remodeled, you don't see it anymore. If this is the truth in the SFA, why not in the profunda? But it's an issue.
Thank you for this interesting speech. Regarding stenting of the CFA, we also know that puncture of a supera stent later on is possible. Do you or any other colleagues here in the room have any experience with closure devices afterwards in the inlining stent there?
All the time. All the time. So I have experience up to 8 French, not more. Some people are asking me, yeah, but in the future, if you need to do a TAVI, 24 French, what's going to happen? I don't know. Probably then you need to do
Which one do you use? I use the Minx control. What do you use?
Femoral.
Yeah. I use the Minx control because I like to leave nothing behind inside the artery. But I think the one, personally speaking, the one you need to avoid probably is a ProGlide. You don't want to destroy, I mean...
Yeah, needle-based suture is impossible, in my opinion.
Pierre?
Controlling all my surgical cases, it's exactly like you say, the problem is not where you make the operation, the problem is the rupture of the plaque and the iliac artery and also the superficial femoral artery. And there is a lot of cases, I can say, where there is big problems with that. I would say for the endovascular techniques, the risk when covering the profunda is not to arrive to get in again. So there is the other techniques, which is with 2 guide wires and to let guide wire inside the profunda.
Yeah.
I like this technique too.
Yeah, you can do this, but so I'm also not afraid of losing the profunda. That's not the problem. The problem is what our friend was mentioning here. If there is at the end a problem with the supera, with the profunda, how can you solve it? And that's indeed something that we need to learn, we need to figure out and to see how we are dealing with this.
And also because a retrograde punch, ultrasound guided of the profunda is easy peasy.
Yeah.
Martin?
Maybe it's sometimes better to lose the SFA rather than the profunda.
Correct. Correct, I agree. And if I see that there is really a disastrous disease on the level of the SFA, it happens that I say, okay, I go for the profunda. And I start my deployment of the supera in the profunda, and I go all the way up. And then at the end, I go through the wires and go and try to make something of the SFA. If it's occluding in the future, there is no critical limb ischemia. Okay, because these are serious complications in both arms. It can be worse, by the way, in the open arm. And this is a case that a couple of months was in my center. Look at this. So this is really a false aneurysm infected. I need to ask the people there. If, again, I tested, but the order is, can you delete this slide, this picture here? Because there is something more interesting on our case, on the on the
I don't think
but probably it doesn't work. So I wanted to show here the case, our case. So after day 12, at day 12, the patient was coming back and there was redness, infiltration, heart, some superficial infection there. So just to point out that this is not so exceptional, especially in diabetic patients, obese patients. Operating in a groin is always challenging. And this is completely, they are not able to delete this, but this is completely in line with the literature, where you see that complications are there between 5 and 15% of the cases. So lymph leakages, most of the time it is superficial, but there is also in some 2 to 3%, there is involvement in the deeper, up to the patch, in the deeper areas. This was a case, for instance, not our case, by the way, where you had this pulsating pseudo-aneurysm completely infected, and every surgeon in the room knows that this is really a very challenging situation to solve. In our case, the endovascular approach, I had some hematoma in the contralateral groin. That was the complication there. And it's also not always like this. And we all know that in some cases, Raphael is not here anymore, but with some bad SFA or common femoral punctures and bad closure at the end, you can also have this immense hematomas, life-threatening sometimes. And so, but they can have some complications, so we try to avoid this. And then, of course, everybody is mentioning, yeah, okay, but on the longer run, I'm sure the endarterectomy is better. Day 180, perfect results. Day 360, day 720. I'm reading in the reports of the open surgery, perfectly patent common femoral artery, no evidence for restenosis. Fantastic. And this is completely in line, by the way, with the literature, where you see even after 15 years, you have amazing results with patencies over 90%. So really impressive. Take care. This patency in these articles is based on Rutherford-Hahn criteria. So maintenance of the flow, visible flow. It's not the same as in endovascular. Because I'm also reading in the endovascular situation, scenario 2 of my patient at day 720, perfectly patent supera in the common femoral, patent deep femoral artery, no evidence for restenosis. But this is based on the much more objective PSVR measurements, what is never done in the classical open surgery. And so also there we need to compare apples with apples, the right patency with the right patency. And so you can say, how do you know this, that this supera was perfectly patent at 2 years? Well, this is based on our study, the VMI CFA trial, where I have a follow-up in 100 patients with supera in the common femoral artery. And I know you are always asking when you're going to publish it. Well, it is under review, Lorenzo. So
it was presented at Viva years ago.
It's going to be very soon, believe me. These are the data. 1-2 year patency, 95, 93% at 2 years. Freedom from TLR, 97.8% with the supera in the common femoral artery. Of course, sliding doors, as you can see, we still don't know it. What's now the best scenario 1? Missing the train or catching the train? I don't know.
Getting a boyfriend or not getting a boyfriend?
Voila, that's the clue. So there is only one way to know it, and that's randomizing it. And so we are working on this. We are running right up to now the SuperSearch randomized controlled trial, 286 patients after a stratification process, 1-to-1 randomized. I don't go in detail on these endpoints. I just want to show you the current status. 198 patients are right at the moment, so almost 200 patients are enrolled, are randomized, 70%. So we need to continue, I think, the remaining part of the year, and then we will have the ultimate answer on this. And I'm inviting you all to this PVI Congress in Paris, where I'm going to give you the first insights in this preliminary situation of the super search. Thank you for your attention.
Thank you so much. Thank you so much, Koen. As always, provocative, but straight to the point.